Happy Wednesday, everybody. Good to see you all. Hi, Dexter. Good to see you. If you feel comfortable turning on your camera, I see folks are doing that. That's awesome. Welcome to what month is it? May's Community Conversation with CFHA. Really excited for this one. Really happy to see so many people. We had 86 people register for this, so that's one of our highest. The community conversations are really intended to be kind of laid back. Let's pretend we're all in a conference room somewhere, popping in and discussing a topic that's relevant to us, that we just want to share ideas and see what other folks are doing to improve patient care and our experiences with team-based care. So our topic today is ADHD screening and workflows. I have no idea why this is so popular, no clue. But I'm really excited for our two super participants today. Hilary Leamer is with us and Yajaira Johnson-Esparza. And they're going to be helping us just start off the conversation talking about ADHD, screening and workflows and intervention in our settings, kind of their experiences. So I will let them introduce themselves. Hilary, do you want to just briefly introduce yourself before sharing your slides?
Hi, I'm Hilary Leamer. I'm an LMHC. I work at Hyde Park Pediatrics as an integrated behavioral health clinician. So I just took on this role about a year and like 4 months ago. I used to be a community-based LMHC at schools. So that's a little bit about me.
Awesome. Thank you. And Yahaira?
Hi, everybody. I'm Yajaira Johnson-Esparza. I'm a board-certified clinical health psychologist, and I am associate professor in the Department of Family and Community Medicine at UT Health San Antonio, where I also oversee the behavioral health curriculum for the family medicine residents. And I'm excited to be here. I am not an ADHD expert, but I can talk about the pathway that we have at our clinic.
Awesome. Thank you both for that. And I forgot to mention, if you all want to put your name, your role, your organization in the chat, that's super helpful for all of us just to know who's in the room, and be thinking of any questions or experiences. I'm sure you all have a lot of them that we can be asking of each other. After Hilary shares her slides, we'll have a chance to just jump in and talk about this. So, Hilary, do you want to kick us off and share? Yep.
So hi, everyone. So this actually came up in our practice. So I work with 6 pediatricians and 3 nurse NPs. And we were noticing that a lot of families were coming in with, can you see my screen? Awesome. So a lot of families were coming in with concerns about attention and attentive schools were sending them in. So we wanted to create a protocol that would sort of streamline the process to help the behavioral health and also the pediatricians and the nurse practitioners. In our practice, the behavioral health, we do not diagnose. We can, but we do not diagnose ADHD because we want to do it as a very collaborative setting with doctor input and having that conversation. So that was one of the things. So our goal was to collaborate and streamline the protocol to navigate ADHD evaluations with families. So we would get these messages by my chart, the triage nurses calls in, or during well visits. A lot of times, this would pop up. So this was all created in a protocol with the BHCs, the triage nurses, the providers, and the front desk and managers, and the nurse manager. So we had all parties involved with this to know what barriers or flow would work for them. And so then we created a script for the front desk and the nurses so that when that call came in, they knew exactly what to do and who to send it to and how to flow it. And so we also created it where the families had easy access to the questionnaires. So we could send it via MyChart, or I created a Google Drive so that they could send out a link with the Google Drive so the parents could have the SNAPs, the Vanderbilts, all the forms that we wanted so that the doctors would have them. Because what was happening is a lot of the times the parent would say something like, hey, we have this concern. They wouldn't get the screeners filled out, and then they would have this appointment and sort of be like, what are we doing? Because we have no information. So we created it so it was very easy access to get all the information that they needed. And then we also created handouts. So a lot of times processes can be very frustrating for families, like not knowing what next steps were. So we created the parent handout for 13 to 18-year-olds. I mean, sorry, 6 to 18-year-olds of like what the checklist looked like a little bit and like what the process was through meeting with behavioral health, then to the pediatrician, and then and if medication was prescribed, that follow-up protocol, what would happen with that. We also created ones for 18 plus who were like out of the home and going, oh gosh, what's happening to me? I'm in college and this is not working. So that they could see what the process was and steps that we could support them with. And so a lot of it was about collaboration and communicating. So once they came in, it would happen is like protocol would be that they would meet with BH first. We'd have all the screeners, all the information. We'd input it into the system. We would do our observations. We'd reach out to the schools. We'd reach out to which parties we think would be the best fit or that they wanted us to talk to. And then we'd synthesize all that data and give it to the pediatrician to sort of see. And then once we had the conversation, we would say, okay, go ahead and schedule a follow-up visit with your PCP for, to discuss possibility of the diagnosis and medication if that's the route you want to go. And then they would meet with the PCP, and the PCP would do the official diagnosis. And then we would also provide psychoeducation as a behavioral health in that moment before we sent to the PCP. We also could supply a letter of support for a 504 or an IEP with the official diagnosis so that, if a kid's having problems with inattentiveness, like, okay, they have this diagnosis now, let's put these accommodations in place to support them. And we also had conversations with school. The only tweakage we would have, if they already had an outside consult and they already were diagnosed with ADHD, they didn't necessarily need to come to BH first. They could go to the PCP, but the PCP would always recommend to come back to the BH just for the psychoeducation and just for that, having us as a resource for navigating whatever may pop up. And then what we would do is I'd review the patient and parent concerns. And I would separate. I would do the parent first, and then I would do the kid to see if they actually saw it as problematic or what was going on for them. I would take any prior evaluations. If the school did a neuropsych, any evaluations, whatever, even if they have an IEP 504, I would ask for all that information just so that I could synthesize it all. Also, if the screeners weren't done, because that was one of the problems we were hitting a lot, was I'd actually have them do them with me right there in that time so that we could have them done. And then if the teachers weren't done, I'd actually be like, can I have the teacher's email, please? Can you sign this release? And then I'm going to do that step of making sure that we get that information. And then what we would do is we'd synthesize all the information, have a conversation with if it's not a clear-cut case, we'd have a conversation with the PCP. And also sometimes when it's not a clear-cut case, I would do another screener, like a scared or anxiety screener, just to see if there was something else going on for the kid. And then typically if it's like one that's not clear-cut, we would then have a conversation about doing outside neuropsych testing. So that's that.
All right, Hilary, thank you so much. So just so I understand, the role of BH in your system is to, if someone calls, wants the ADHD, I want to know what's going on with my child. This is mainly pediatric you're talking about?
Mm-hmm. Yes.
Okay. So then you start with BH and you run them through the screening tools. So
yeah.
the BH is sort of the facilitator of all this.
Yes.
At first. Okay, that's wonderful. Thank you. Yajaira, excuse me. Do you have any comments, or you want to take us through kind of how you conceptualize?
I can tell you what we do, and I'm going to apologize if I misread the email, but I have our adult ADHD pathway.
Yeah, that's super helpful too.
Okay, great.
Yeah.
So we have a pediatric, and then I'll talk a bit more about the adult pathway.
Great.
I was very excited to hear about what you all do with the pediatric population. We have a lot of folks that come to our clinic asking for ADHD evals. And I should mention, we serve a very socially and medically complex patient population. So there are so many pieces that we have to consider. which is why we had to develop this pathway mainly out of this need that became apparent. So whenever a patient does come in requesting ADHD medication, an adult patient requesting ADHD medication, or even just asking for an ADHD eval, the very first step is it activates the pathway. Even if they're coming in with prescribed medication, if we don't have any records that demonstrate that they have been adequately evaluated, and this is whether it's past medical records or an evaluation from a psychologist, then we'll go ahead and initiate this pathway. And it'll be even during we might do it during a warm handoff, or we might be scheduling folks. It is a 2-part visit. We still adhere to the PCBH model, so we don't have any visits that go beyond our typical time that's consistent with PCBH. The first visit consists of conducting that contextual interview and a functional assessment of the problem. So figuring out what the onset of ADHD symptoms and your 3 T's basically, and the impact of functioning, with some questions that are very geared toward assessing the presence of ADHD symptoms. And that might include the patterns of inattention and executive function, cross-setting impairment, developmental persistence, any of the functional consequences associated with that. We'll then also administer the ASRS-5, which is a very brief symptom-based screener. It is not a diagnostic tool. It is more of a screening tool. And then our usual PHQ-9, GAD-7, a quality of life assessment to rule out depression, anxiety. But we also rule out bipolar disorder and other things that might potentially overlap, or where the symptomatology might overlap with ADHD. So if there's any indication of trauma, we'll assess for PTSD as well, recognizing that itself can be a factor that drives a lot of these symptoms. We'll do a pretty thorough chart eval to see whether there are any medical things that might be accounting for some of these symptoms. And that might include looking at thyroid, do they have sleep apnea or other sleep-wake disorders, chronic pain, substance use, a history of TBI. So that gives us a little bit of an idea of other factors to potentially rule out. And that completes our part 1 visit. Really just ruling out several things and getting a good sense of whether, even developmentally, whether we can actually whether there's a point to continue pursuing an ADHD eval. I've had patients who say, well, this just started 2 years ago, and I think I have ADHD, but then when you start in that initial visit, you realize that a lot of it is driven by anxiety or something else. So at that point, we might shift gears and focus more on that anxiety. But this first visit allows us to do that. For our second, sorry, I'm getting winded here. For our second visit, we'll go ahead and, I should mention that during the first visit, we'll obtain any additional records. If they did in fact have an evaluation, we'll still schedule the second visit, but we'll try to get those records ahead of time. And if necessary, we'll conduct a second visit. If those records confirm a diagnosis of ADHD, then we'll cancel that second visit and just add it to part of our evaluation, make sense of that, send it to PCP for additional review. But otherwise, we'll come in for the second visit. In the second visit, it's more geared toward getting a childhood history of ADHD symptoms using the Wonder Utah Rating Scale. So this really is most helpful in giving us an idea of, it helps us establish that childhood onset. It allows us to separate bona fide ADHD symptoms from acquired executive dysfunction. So that becomes the point of the Wonder. To assess for executive dysfunction or functioning and / dysfunction, we'll go ahead and administer the MOCA. I know that when it comes to the MOCA, folks might think, that's really more of a neurocog screening, and that's fine, but it can be very helpful when we're dealing with cognitive complaints, when these are quite prominent, which is the case with many of our patients. We do emphasize attention and working memory performance when we administer the MOCA. And then we also administer the TOM. I don't know if any of you are familiar with the TOM. It is an effort. It's a measure of effort. So it gives us an idea of whether a patient is putting forth good effort into their evaluation, or whether there's any possibility of, I don't want to say feigning, but for a lack of a better word, I'll say feigning. And that completes our 2 visits of the ADHD protocol. We take all the information we gathered. Of course, we also look at medication to see whether there are any medications that could be contributing to some of this dysfunction. Everything, of course, keeping in mind the onset of the problem. And based on that, on those two visits, we can go ahead and come up with a determination of whether we're looking at something that's more consistent with ADHD or better accounted for some others, or better accounted by some other stuff. There are instances where it's quite gray, and in situations like that, it becomes clear that perhaps referral to the community might be better so that they can undergo a more complete battery of an ADHD evaluation. So there are instances where we might do something like that as well, if we really can't come up with a good conclusion.
Great.
That was fast, sorry.
No, thank you. Thank you. That's very helpful. Thank you both. I want to share a little bit coming from my perspective is one, although I've been practicing for a while, I think I've been quite, I almost want to say dismissive of ADHD in favor of trauma history, anxiety, which I've just had much more experience and training in those areas. And I've been really humbled lately after reading a few clients' neuropsych testing results. After they were interested in pursuing an ADHD diagnosis to see what was going on, and really looking at kind of the impairments for people's working memory and running into this clinically where folks have trouble identifying emotions in session. They're having trouble tracking what we're going through in talk therapy, right? And some of that I'm realizing now can be attributed to ADHD after reviewing neuropsych testing. So I just sort of wanted to put that out there for anyone on the call who feels like a complete beginner or feels a little bit like a fish out of water with ADHD. I'm wondering for people on the call, like in integrated care settings that I've worked in, there was no one to refer to for neuropsych testing, and there was wait lists for 100 years to even get that. So for either of Hilary or Yajaira or anyone else on the call, just to clarify, who's making that diagnosis in your health system? Is it based on the screeners and batteries that you're discussing, then you're coming up with that diagnosis in behavioral health? Or is that PCP?
So in my instance, a lot of times it's my observations, it's the parents reporting, the school reporting. I don't do the official diagnosis, but I will say this is my recommended diagnosis to the PCP.
Okay.
And they will either agree or disagree. And then if it's sort of like we go from there, depending upon what the thought process is and where we should move forward from that.
Based on all the screening tools and batteries that you described, that's where you're getting the diagnosis.
Yep.
Okay.
Yep.
Okay.
And in our case, we will diagnose ADHD ourselves if it becomes very clear. Many times it's better accounted for by something else. But there are times where even the presentation in the room is very consistent with the ADHD, and based on like our 2 visits and having had contact with them during a meet and greet and just speaking with the provider. So we will our providers rely on us for that diagnosis.
Great. I think it's an important conversation because of how popular and the discourse has become on social media and just in general. And we are seeing a rise in diagnosis. And I've heard lately in a few presentations that I've attended that we're able to track ADHD in women and girls a little better than we were before. Does anyone have any comments, either Hilary or Yajaira or anyone else, around sort of seeing the diagnosis, seeing more patients coming in, requesting, any changes with females, or anything we should be looking for specifically?
One thing that I've noticed, sorry.
No.
Good. Okay. So I think it's so interesting that because I work in from ages like 0 to 22. So I'm getting a different like look on things. But I'm noticing a lot too, that when we're talking with the doctors about the screeners that come in with like the Vanderbilts or the Connors and things like that, it's a lot of times it's behavior based. And so when I have those conversations with like the parents or the kid or the teachers, I'm like, tell me how the inattentiveness shows up. Like I need to know, because they're not a problematic child with behaviors, but they're not getting their work done. So I need to see what the piece is for that. So I've actually had more females coming in and me sort of targeting questions with that idea about the inattentiveness and how that's showing up in the classroom and at home with the executive functioning skills. So I feel like people are getting higher diagnosed when they have the inattentiveness because we're asking the right questions in that domain.
Mm-hmm.
I already lost the question because I was answering some like
I
another
know, I see.
question.
However, the chat's on fire. Yes. The question was women and girls, does behavior, and kind of we went to like the behavioral issues may not be as present with girls potentially for the ADHD diagnosis. Are you seeing a rise in requests for
Yeah,
diagnosis?
that's interesting. I have it's interesting because we do also have treat pediatric patients, and I do see a lot of that is managed by the schools or by our PCPs. But I definitely see way more boys who are coming in for those evals, though we
Mm-hmm.
know that there should be more girls who should be coming in, and we're just kind of missing them. Um, for the reasons that you mentioned. I have had some adults come in and say, I know that as women, we get underdiagnosed. So I think
Mm-hmm.
you really need to you really need to evaluate me because I'm having X, Y, and Z symptoms. So we do have a little bit more of that awareness that it can be underdiagnosed among women.
Mm-hmm.
Um, so folks are coming. I do get a few more women that have been coming in. I think when it comes to the adult population, I probably see as many women as I see men requesting ADHD evals.
Okay. But just for folks on the call, so sort of tracking that conversation, some of the screeners are going to focus on, do you get up out of your seat? Do you interrupt the teacher? Do you, sort of that behavioral stuff that maybe girls are not doing as much potentially, right? So something to just to be aware of. I want to go to the chat. Julia has a question for Hilary. Post-school stuff, do you use different screeners for those folks who aren't in school to get a Vanderbilt? And go ahead.
Yeah, so it depends on the age. So if it's someone who's 18 plus, I don't tend to typically use the Vanderbilt. I'll use the ASR 5 with that, and the self-reporting one, I'll have them do that. But if it's, and I actually will sometimes have them do the cars also, just to sort of really get a more robust look. But then I also really like the snap, just for like a boss to do the snap. If they're comfortable with a boss doing the snap or like a partner doing the snap, just to get an idea of how other people are viewing what's occurring for them. And so that's typically what I do.
Great. Thank you. And Travis says that in a few presentations he has attended, recommendations have moved away from needing formal performance testing to confirm a diagnosis, so like maybe neuropsych testing. Have others shared this, that maybe we don't need neuropsych testing to make this diagnosis? And Travis, if that's not the right question, please feel free to come off mute.
Nope, that's the right one.
Okay.
Yeah, just recently had a neuropsychologist at the organization I was working at gave a presentation to the broader behavioral health department, and it seems that the recommendations, and this is kind of broader field recommendations, that the kind of added benefit of doing performance testing didn't add much more than the clinical interview and doing collateral questionnaires and a lot of the great things that people are talking about now. So that's the only place I've come across it. I'm wondering if others have too.
That's interesting, because although we administer the MOCA, I don't always rely, like sometimes people perform pretty well on the MOCA and I still end up diagnosing ADHD because I'm diagnosing it based on my contextual interview on obtaining information about the impairment across multiple settings and several of the dysfunctions that they're reporting. But also because I recognize that through their education and scaffolding and whatever, they are able to perform pretty well on the MOCA. But we still administer it because sometimes we are able to detect some dysfunctions that can be helpful in our own treatment of patient or helping facilitate with compensatory strategies or whatever it may be. But it does play a role. It is not the sole indicator, and I think that makes a lot of sense because I think just through schooling, many times people are able to develop skills to compensate for some of the ADHD symptoms that would impact performance otherwise.
We have another question for you, Dr. Johnson-Esparza, around, are psychologists only allowed to administer some of these assessments? I don't know if you would know that.
I think I think that the MOCA can be administered by other folks. If our residents do it, we still, as the behavioral health faculty, will still review it to make sure that we are overseeing adequate administration. It does require a training. So the MOCA is one where there is a training to get certified, and once you're certified, you're able to administer it. The TOM, I don't know. That's a really good question about who can administer and who cannot. I would just make sure that if anybody is administering something like this, it is under supervision so that they can be able to talk about the role of these psychometric measures in their evaluation.
Okay, that makes sense. And then we had a question from Alex, is anyone using the bars 4? Doesn't look like it. And if anybody on the call is using it, please throw that in the chat. I think these are great. So keep the questions coming in the chat, and we will get to them as quickly as we can. And if anybody wants to come off mute and ask a question or add to this conversation about what you're doing or what you're seeing, we can leave a little space for that. Okay. So as I'm thinking about integrated care settings that I've been in, now that I'm thinking about it, this was just sort of like knowledge that we would all carry forward that, oh, we don't diagnose ADHD, right? And this is a few years ago at this point, but it was like, no, they need neuropsych testing, which sounds like we're maybe moving away from that, and that would make sense. But I think we need to talk about the role of medication because in the integrated care setting, I think that our PCPs sometimes are reluctant to prescribe medication, especially to children or even adults, that it's things like Adderall or Vyvanse, and they're looking for that extra confirmation that we can provide or someone can provide to like say, okay, this is the actual diagnosis. So I think part of what's happening is that it's like a hot potato because the prescriber is a little bit reluctant, potentially. Some folks are nodding with that. That's just my read on the situation. How are we handling medications or what are we seeing that's helpful for patients? How do we talk to parents about meds for their kids? Just anywhere you all might want to take that, Hilary. Maybe I'll put you on the spot.
Luckily, the pediatricians here are very well trained and well knowledgeable in ADHD medications. There's some places where they're like, nope, we're not going to do it because of this age, and that we want to do a psychiatrist. But we also have already created a resource list for us to help support reaching out to a psychiatrist if that be the case, or a developmental pediatrician. So we've already created the list so they're not just left hanging. And so the way we also do it is that they don't have to, when we go send them to the PCP to have the conversation, they are also getting the psychoeducation about medication in that conversation. It's not just that they have to take it, but sort of here's an option available to you with these things. And so they'll do the medication, and then they do the 2-week and then the 3-month checkup, and they're very much on top of those checkups and things. And then when we a lot of times actually continue to see the kiddo in a sense of for a month spot check-in, or the parent will call us and be like, hey, we're having this really rough time, we also check in and be like, how are they doing with the medication adherence, things like that. And then we can give that information to their pediatrician to sort of make sure everything's moving along. And then if it becomes where it's sort of oh, we got to go out of house, we have the resources available to do out of house for them.
Okay. So PCPs or external to psychiatry.
Yep.
Our PCPs will prescribe medication both for kiddos and adults once a diagnosis has been provided. With kiddos, we will definitely engage in behavioral interventions to make sure that we are providing skills and we are teaching parents how to create the structure that might be needed, especially because many parents do like to have some of those medication breaks and vacations, especially during their actual vacations. So we want to make sure that we continue to provide support along that and to really highlight the role of behavioral interventions. The medication's fine, but if you continue to not provide adequate structure and not use the most effective parenting skills, we might continue to have some behavioral problems, right?
Right.
So we do try to pair that. When it comes to adults, one of the reasons why we initiated the pathway or started this pathway is because there was a lot of reluctance to start ADHD meds, even when there was a patient who would benefit from medication. Because maybe we did have a confirmed diagnosis. So we wanted to create a sense of security for our PCPs and help them feel a little bit more confidence in prescribing this without thinking or without that worry of, is this going to be someone who really is just taking advantage of a medication? And that's why we do this. And we will have follow-ups to provide additional skills. We've had patients who start on medication, but they still say they want to be engaged in behavioral health visits so that they can develop better skills to manage their ADHD. And we love seeing that. But, we did have like some folks who didn't want to, someone mentioned here that even when they transition to adult medicine with a standing diagnosis, some PCPs are still reluctant. That's where as behavioral health, we come in and we're able to talk to the PCPs about, we have a confirmed diagnosis, they've been on this, psychiatry had diagnosed it, and this is how it's still impacting their functioning. We think that we should continue the medication, and we're able to work with our PCPs very well when it comes to situations like that.
Yeah, that's awesome. So your role transitions a little bit to patient advocate, reminding why this person is on that medication, how it's still impacting their functioning, so that PCP then has that top of mind. That's excellent. Lucy has an awesome question in the chat, which I'm surprised. I almost forgot about this. So thanks, Lucy, for bringing this up. When substance use is a part of the equation, how do we sort out if it's substance use and ADHD? Go ahead.
Yeah,
Yajaira.
that one is, I'm assuming that's for the adults. Hopefully not for the pediatric patients that were asking that one.
Them too.
All of them too. Yeah, you're right.
Mhm.
So, it is tricky, but that's why we want to establish childhood onset. One, we decide to establish childhood onset with the vendor. Sometimes collateral from a parent can be very helpful in helping us establish that childhood onset. But we also will administer screeners to get an idea of the extent of any kind of substance use. And we will assess the history of substance use as well. There are times, and this is not directly relevant to substance use, but there are times where you have, say, anxiety onset coincides with ADHD symptoms onset. That gets really tricky, where we then have to kind of tease apart whether we're really looking at anxiety or something else. So I think a similar approach gets taken when we're talking about substance use, where we realize this is the onset of the substance use is really, say, a couple years ago, but these symptoms have been ongoing since the age of 10. I think that's a really strong indicator that we might be looking at ADHD. What's hard at that point is to determine whether the current impact in functioning is due to substance use or actual ADHD symptoms, because we do know that people tend to outgrow, if you will. Some people can outgrow these symptoms or learn strategies that can help them be functional. So when that's the case, when it's really challenging for us to determine whether the impairment in functioning is related to substance use or ADHD, I think the immediate go-to becomes address the substance use so that we can make sure that we are in fact targeting the right thing at that point.
I hear that. I hear that. And I'm working with someone right now who has a diagnosis of ADHD and also intermittently uses cocaine, which I just found out about. So keep that, I would say just keep that in mind too, that likely that you may be treating ADHD and never know that somebody's using other things for a while until you work with them for a minute. What I find has been helpful is, yes, talking to her about that we're not going to truly know what is inattention and hyperactivity and these disorganization symptoms unless we also like tone down the cocaine use, right? Unless that starts to come down and we get a period of actually knowing what your baselines are for any of the mental health conditions. But for her, she has a family history of neuropsych disorders, right? Which is like, okay. And also, really has trouble organizing herself even when she's not using. So it is hard to tease those things out. But I think they can be worked on concurrently and just being really upfront with the patient and the client about what you're seeing.
So in the
Go ahead,
in the
Hilary. Yeah.
okay, in the pediatric field. So luckily, because we're affiliated with Boston Children's Hospital in Massachusetts, there is actually a substance use program. So it could actually be a concurring treatment going on where they could be doing the substance, working on that, and then we could be like exploring the ADHD aspect of it and things like that, and also like working collaboratively in that way, which is really nice because with substances, you're like, which ones came first, or is it both of them?
Right.
And so it's, and a lot of times when I have kids who come in and be like, well, I smoke pot and I'm having this difficulty, I'm like, okay, so I would like to know what your baseline is when you don't smoke. And that's typically what I do. And then, because sometimes kids are not willing to do the substance use program at all, or the parents are like, they're unable to get them to, there's just a lot of barriers. So sometimes you got to work with what they're coming in with, but sort of do the circumventing thing with the substance use and help them explore that idea too.
And I just a shameless plug, I do a little bit of work with the Illinois Primary Care Association, and there's a podcast we recently did called Health Talks. So it's IPHCA Health Talks podcast. And I interviewed a doc who does adolescent substance use work at our big major hospital here in Chicago. And she talks a lot about teasing out substance use and ADHD in that podcast. So that might be helpful to some folks on the call. I wanted to offer Julia, Dr. DeJoseph, did you want to, if you're still on, you want to come off mute and
on.
Yeah, do you want to share your comment in the chat?
Sure. I was just saying that when I'm a family doc and I'm also a medical director, and with regard to PCPs having anxiety or refusing to prescribe, I do think that primary care and just physicians have been burned. I mean, all medical providers, but have been burned for a long time by controlled substances. And so there's a lot of lack of trust given the opioid epidemic and the negative outcomes we've seen with that, which then created additional diseases that we have to treat, as well as like benzos fall into that. And so I think with the stimulants coming up, even though it's really a lower risk of addiction, it's still really hard for us to feel that trust. And so I think part of why I and many of my associates are on this call is trying to find that way to become comfortable. And I do think that teamwork and that team-based care. I mean, I love integrated behavioral health. So I know that this is the prime spot to talk about that. But I think it is so helpful in hearing what the teams have done to integrate BH around ADHD has been really pretty paramount into gaining that comfort and not feeling like it's just on you as the prescriber, as the assessor, as the maintainer. And so having that partnership, I think, is really key. So I appreciate that.
Yes, and thank you so much for you and your colleagues for being here from the medical perspective. And that's always helpful for us in BH to hear what helps you all in team-based care. So thank you for that. Please keep the comments and questions coming. Yes, I will put the podcast in here. Let's talk a little bit around, I wanted to ask if anybody has experience with executive functioning coaching, because this is also a recommendation that we give to our patients and parents. Parenting training, sure, but for adults, I've seen this, right? So medication is one way, and then functioning coaching. And for the life of me, I'm not sure who does that. Is that something that you can get certified in? Is that therapists are supposed to do that? But when we're already doing it, we don't know. If anyone has expertise on that, or know what that is, I would love to talk about that. This is where we would recommend, helping a patient who has ADHD around the behaviors, right? So how are folks doing that?
So I do a little bit of executive functioning coaching, like sort of
Yes,
spot
awesome.
executive functioning coaching, just because I have ADHD myself. So I've learned systems that I've had to do. It depends on the case, right? Like if it's sort of like setting up like little things, I can do it in-house. But there's other places that I will actually send children to for executive functioning coaching. A lot of speech therapists are really great at executive function coaching. I'm just going to say the person that I absolutely adore here in Massachusetts is Sarah Ward. She is phenomenal. And she has a website, so you could actually go and do tools on there too. About executive functioning. So a lot of times I will do it in-house, and if it's not working, that's when I will typically do referrals out for executive functioning. I also do a lot of education towards families and parents about executive functioning, because they always think it's like just this one domain. They don't realize it's like 12 moving pieces in this domain. So someone may be really great in this area, but they can't do task initiation, but they can do planning. So it's a lot of teaching psychoeducation regarding executive functioning and how that shows up and how it may be different for everybody. So yeah.
Awesome.
I hope I answered the questions. I'm sorry.
You did.
We take a very similar approach. We'll provide skills within the context of our visits, focusing largely on the areas where they're experiencing most of the impairment in their functioning. But for like, it's interesting. I hadn't thought about actually finding certified coaches to be able to connect our patients to, and that seems like that might be a cool opportunity for some patients. But we will try to provide as much as possible some of those skills in-house, given also that our population tends to fall out through the cracks and requires a lot of those same-day visits and ease of access issues that come up.
Mm-hmm. Anyone else on the call specializing in working with folks with ADHD or have some clinical tips that are working? Okay.
There's a book that I really like. It's for kids. Sorry, I'm very kid-based. But the parents like it too. It's called Surviving ADHD. And it sort of gives like little quizzes for kids to take to see, because I think when people say ADHD, they just think it's like behavioral and they don't understand all the underlying things.
Yes.
And this book is really great about like sort of exploring how your ADHD shows up. How does it show up in your life? And it's really great about giving little strategies, but also like helping you understand that it's not like this horrible thing, but it's just sort of an operating system. And how do we work with this operating system?
Great. Thank you. That's very helpful. Thanks for sharing that resource. And I see, Tara, you put another resource in the chat. Thank you. I also posted the podcast for people that are interested in that. I'm going to go back up to Amanda's question. Oh, Christian, go ahead.
Yeah, Christian. Yeah, so I also think like just baseline having like a neuroaffirming perspective on the treatment that you're engaged in is a good idea, just to give context to the fact that it's like the pathologization of ADHD and the fact it's not a bad way to be, it's just a different way. So I think like that baseline is something to offer to patients that you're seeing. Also, shout out to Julia, I work with her.
Great. Thank you. Thank you for your comment. Amanda Crane, I'm going to share your question and comment unless you want to come off mute. Okay. The question is, if a provider wants to monitor some of the signs and symptoms as they are working through skill building and medication management, what are you using to monitor? When do you find it's helpful to engage in some level of check-in or monitoring? So how are we monitoring patients over time after the initial visit and diagnosis, let's say?
Okay. I know Hilary's the one who's doing kiddos, but with our kiddo population, we might still use like the Vanderbilt, which has a follow-up version once the kiddo is on medication to be able to track how they're doing. But I'll defer to her. I'm really interested to hear what her team does. As far as adults, we we're not using a formal assessment or screener to help us kind of gauge how well they're getting with like certain ADHD symptoms. We continue to use our quality of life scale to get an idea of like any improvements in their quality of life, but a lot of it based on their self-report and like their subjective experience of improvement with symptoms. So not the most scientific in that regard. But our patients are really good of letting us know when they feel like they're actually able to produce a little bit better at work and function better.
Right.
So yeah, a lot of the same things. We do the Vanderbilt follow-up, but a lot of it's actually self-reporting, which I really like. And when I have conversations with teachers, because so initially when I have a conversation with family, we set 2 goals. Like, what are your 2 goals that you're hoping to do with, like, you know, the executive functioning skills that we're doing, or with the medication? What is the 2 manageable goals that we're looking at? And so we will sort of track it. And the families see the doctors quite often for the medication management to look at it and see how that's going. And I give psychoeducation of like what progress looks like, because a lot of times parents have a misunderstanding of what progress would actually look like with medication. They think there'd be like this whole change when it's like, actually, no, you just want to look for 1%. And as we build upon that. And so a lot of times it's self-reporting, like, hey, how's it going in school? Are you getting redirected less? Are you getting along with the friendships? How's the emotions coming along for you? How are we managing emotions? So a lot of times it's self-reporting. And a lot of times the kids who we've met with, like typically the family will come in once a month meet with me, or the kid will come and meet with me once a month, just so that we can continue to sort of see how progress is going.
Great. Thank you. Thank you for that. Thanks, Amanda, for the question. Lucy asks, how much of the ADHD specific visits do you typically do a week? We have a lot of patients asking for ADHD diagnosis, and as we're trying to figure out workflows, what's a sustainable volume?
We have a pretty large clinic, and I don't think I can tell you how many I see a week. Actually, I don't have ADHD evals on a weekly basis, but I do probably have, and it's 2 of us, and I don't know. I can't speak for my colleague, but I personally maybe have like 1 to 2 evals a month. For ADHD, I should say it comes in waves. I don't know what it is. Sometimes everybody needs to have an ADHD eval, and I feel like I'm having ADHD eval after eval. But then for the most part, I think we're looking at 1 to 2 a month.
So typically, I have a co-clinician, and we're typically getting, I would say, 2 to 3 a week for it. And you're right, it does comes in waves. And a lot of times with school-based children, it's when grades have come out, when teacher conferences come out, or the end of the year. So that it's typically certain times a year that we know we're going to get slammed with these evals. And then typically it's like 2 to 3. Her and I will have like 2 to 3 a week.
Okay. That's helpful. I would also think it's just an easy way to engage people in behavioral health in general. If they're coming and asking for a specific eval, you're still able to sort of take them through, do a little bit of coaching, set some manageable expectations, right? But I can imagine folks are getting inundated as well. So I'm hearing, just to recap, having a workflow is really important, and a plan, because I don't think that the requests are going to stop coming anytime soon. So understanding what your PCPs are comfortable with and what kinds of support they need, having resource lists available, external referrals, developing some kind of screening protocol. There's many, many screeners mentioned here today. Follow-up cadence, establishing that. And then probably some training, right? I would think that the clinical teams need additional training in your PCPs as well. Any training recommendations from our super participants on how you all got trained on this, or treatment, or?
I think honestly, it was a lot of self-reporting, like watching a lot of people talking about like a lot of like their experiences, or how they were misdiagnosed, and how like a lot of times how they were upset about it. So I do a lot of that, and then I would just read. I love to read or listen to podcasts about that the interest I have that month. So it's just like that is where I've gotten a lot of my knowledge from. And also I have a child who's diagnosed with ADHD. So to be a better parent, I had to really understand what was going on for him.
Yes.
I'll talk from the perspective of the clinic. I think what we did was create and actually formalize a pathway and wrote a pathway that was then disseminated to the team. And during our we have monthly team meetings where we have all our staff present. We will go through pathways during those meetings, remind folks of these pathways and go through what that pathway looks like. During our morning huddles, we might remind folks, hey, don't forget, we're noticing a lot of you are dismissing patients when they're talking about their ADHD. Don't forget we have a pathway. So we might do some of those reminders along the way. We also train our family medicine residents. The residents rotate with me. They rotate with my other faculty colleague, or my other behavioral health colleagues. So they also learn how to conduct these visits themselves. They learn some of the questions that are important. So through that shadowing and those co-visits, they're able to also pick up on ADHD evals.
Great. We have just a few more minutes here, so if you've got any last questions, please throw those in the chat. I want to go back up to an earlier question. Is there any level of complexity that would trigger you to refer out? Or is there anything that comes through that says, okay, we're not going to handle this in-house?
Sorry, Hilary, if I keep talking first, I can't I don't know when you're unmuting yourself either. When it's very muddy and it's really hard for me to tease out what's going on, I might refer folks out so that they could have maybe more thorough evals. Somebody mentioned some of those more thorough diagnostic interviews. So we might refer them out in situations like that. I've also referred patients out when they are not convinced with my assessment and they feel like that they're convinced that it is not this, it is actually ADHD, then I encourage them to reach out to someone in the community to go somewhere else where they can have another evaluation. So those are the two instances. For the most part, our PCPs manage the medications just fine alongside the behavioral health consultants.
Great. Go ahead, Hilary.
Definitely with the muddy waters, that piece too. A lot of times I see, the piece of the trauma. If I have kids who have come in with trauma, that is a piece that I'll actually be like, you know what? Not sure which one is happening. So we need to explore this trauma. And I'm not the person to do that piece for the trauma. That's no longer my role. Also, sometimes with high functioning autism, I sometimes have to, sometimes I'll be like, you know what, I'm not sure about if this is ADHD, autism, or a combination of both of them. So I would like to refer out just so that we can get a clear view profile to get the best supports available for your child.
Great. Yeah, that makes sense to me. Tara put a helpful and free video that speaks to assessment in adults in the chat. So be sure to grab that. There are requests for the pathways that you both shared. So if you've got them written down and you feel comfortable, you can email me. I know both of you and I have been corresponding, so you can send those to me and we can hopefully get them out to the membership and those on the call. And then one final question from Amanda. Is there a working diagnosis that you're using until you confirm ADHD or rule out?
Adjustment disorder.
That's what I would figure.
I agree. It is infuriating that sometimes you're like, oh my gosh, what do? I can't just put inattention or rule out, right? But I mean, you can really rationalize it. This inattention is really distressing to the patient. So I also default to adjustment disorder until I can come up with a more solid diagnosis.
Awesome. The speed of this meeting today is making me feel like I have ADHD because we have covered so much. I really, really appreciate everyone being here today and for you taking the time out of your schedules. I feel like we covered a lot. And so hopefully, again, Hilary and Dr. Johnson-Esparza, if you can send your pathways, we'll send them out. This will be recorded, or it has been recorded. So if you need to send to colleagues or anything like that, or use or reference, you can do that through CFHA. And I'm going to give you all just a couple minutes back. Please feel free to join us at our next community conversation, hopefully next month. Email me if you have topics you want us to cover. Hilary and Yajaira, thank you so much for joining us today. And I hope you all have a good rest of your day.